See, I'm going to talk on a very, very important thing which is extremely common in our setup, that is the catheter-related bloodstream infections. Let's take an example first. A patient's 50-year-old male was admitted to the ICU with severe pneumonia. He was hypotensive and a central venous catheter was inserted. He was given antibiotics, fluids and other supportive treatment. His blood culture due streptococcal pneumonia. He became afebrile on 4th day and he was doing well. Then on a 7th, not on a post-operative, 7th admission day, he developed high-grade fever with chills. So this is the kind of scenario where you would think of a bloodstream infection. A person of pneumonia, you gave him antibiotics, you put in a central line, he became better, and suddenly in the following days he starts developing fever. Central venous catheter infection could be one of the reasons for this fever. So most of the time you have to rule out other known causes of fever before you think that it could be a central venous catheter infection. Normally these patients have bacteremia or fungemia which is related to the intravascular catheter, and you diagnose when a patient has at least one positive blood culture obtained from the peripheral vein and has clinical manifestations of infections, fever, chills and hypotension, and there is no apparent source for the bloodstream infection except the catheter. That means you ruled out, and one of the following should be present, that is a positive semi-quantitative more than 15 CFU per catheter segment by roll method technique, or quantitative more than 10 colony forming unit per catheter segment catheter, culture whereby the same organism is isolated from the catheter segment and the peripheral blood, or the quantitative culture, there is a higher ratio from the catheter, 3 to 5 times more from the catheter as compared to the peripheral blood. So you should be growing the same organism for both the places. This is one. Then if you had taken out the catheter, you send the catheter tip for culture, and you must send at least 5 centimeter of the catheter tip for culture. Same organism grown, but the growth from if you had sent blood, then the growth from the catheter hub blood should be 3 to 5 times more. Then you say the patient has a bloodstream infection, which is because of the central venous catheter. And the other thing sometimes said is that if you had sent a sample from the catheter and sample from the peripheral vein, the sample from the catheter grows 2 hours before the peripheral blood. That's called the differential time to positivity. So these are the ways how you diagnose a patient to be suffering from central venous catheter infection. So discussing about the epidemiology, it's a very common bloodstream infections, and it is increasing use of central venous catheter in the ICU. Almost 50% of the patients now in the ICUs have a central venous catheters. It disrupts the integrity of the skin, leading to the portal for pathogen to enter into the blood. It is the most frequent cause of bloodstream infection. 90% of the catheter-related bloodstream infections occur with the central venous catheter, and it results in a mortality. It's extremely significant. 4 to 20% in different studies. It can result in death also. And not only death, it also increases the cost because the length of stay increases by 7 to 21 days. What is the causative organism? It will always depend what is the epidemiology of infections in your ICU. One ICU may be different from the other ICU in the same hospital, from hospital to hospital, from country to country. There could be different organisms causing central venous catheter infection. In the Western literature, you will find the coagulase negative staphylococci is the commonest organism which grows, and followed by staphylococcal aureus, enterococcus, and candida infection about 9%. But the studies from our country, you find the gram negatives are much more common. Coagulase negative is much below, only 5.8%. And the Acinetobacter, which is not that common in the Western world, it is also pretty common to the catheter, central venous catheter infection. So gram negative and particularly the E. coli, Klebsiella, or the Acinetobacter are the common organisms which are found in the ICUs in our country. Then which kind of catheter can result more infection. It is maximum with the Swan-Ganz catheter, then the dialysis catheter, and it is least with the implanted ports. The infection is only 0.2%, and with the non-tunnel central venous catheter, the catheter I am talking about is only about 2.3%. Then how does it occur? As I was telling you that when you put in a catheter, you disrupt the integrity of the skin. So you create a portal of entry, or that's the commonest way the infection goes, and the other is the healthcare worker hands. If they don't maintain the sterility, that's another source of infection. Then the contaminated catheter hub, which is the second most common. Then the contaminated infusate, which is not very common because so it is less than 1% and unknown in 20%. Then catheter characteristic, as I was telling you, that it is least with the port catheters. Femoral catheter has the maximum infection, and followed by internal jugular, then the subclavian, which is less, and the PICC line is even lesser than the subclavian catheter. Then the other is emergency insertion. If you insert a catheter in emergency, because you don't take that much precautions many times, it results in a central venous catheter more commonly. Then if duration of catheterization is more than 5 days, that could also be one of the reasons for increased incidence of central venous catheter infections. Then immunosuppression, neutropenia, CHF, total parenteral nutrition, lipid emulsion, the insertion site or hub bacterial colonization. These are the other risk factors for the occurrence of the central venous catheter infection. Then the diagnosis. As I was telling you, I'll just go again that normally if a person is doing all right, there is no need of sending routine cultures from the central venous catheter. You only send a catheter culture when you suspect the person has infection. So let's say this patient which I was talking about, the first thing I will do is I'll send a peripheral blood culture and take a sample from the out of the catheter and send it for culture. Because patient has symptoms, so if I have sent the sample, the growth from the catheter should be 3 to 5 times more than the peripheral vein. That's one. And differential time to positivity should be more than twice. Then I would say, because patient has no other source of infection, the patient has symptoms, and I'm growing the organism from both the peripheral vein as well as the catheter blood, and the differential time to positivity is more than 2 hours, and the growth is more than 3 to 5 times. So I can say this patient has bloodstream infection. Sometimes you decide that I will remove the catheter. So if you remove the catheter, you send the tip for culture. Then if you send a semi-quantitative, it should be more than 15 colony forming unit. And if you send a quantitative after sonification, it should be more than 10 colony forming unit. And the same organism is growing from the peripheral blood. You say the person has central venous catheter infection. Is that clear? I think this is how you diagnose a patient having a central venous catheter infection. Then the other thing is that the signs of infection at insertion site are not very sensitive, as you see in this slide. The specificity is very high, that if you don't find anything, but the sensitivity of these signs is not very high. It's less than, erythema is 3%, and rest of them is even less than 1%. This I have already discussed with you. The sensitivity and specificity of the blood culture is also dependent on the volume of blood you send. You must send at least 10 ml of blood. Skin preparation should also be adequate. The blood should be withdrawn after due care and using a sterile solution when you withdraw the blood. This is also very important. And routine catheter tip culture should not be done. Like if a patient was doing all right because you decided now I should remove the catheter, don't send the catheter tip culture. That's a normal practice. Don't do it. It has been seen that they had sent almost 1,263 catheter tip and only 35 patients had a bloodstream infection. So routinely it is not advised to send a catheter tip for culture. Then is the management. Then the day one, when I discuss day one, you consider on which a negative blood culture is obtained. That's you call it day one for deciding the duration of treatment. Linezolid, which is a common practice, should not be used for empirical therapy because seeing gram positive and this is a common practice to start linezolid. The drug of choice is either vancomycin or teicoplanin is recommended, and if the vancomycin MIC is very high, the daptomycin is a drug which should be used in patients where you are suspecting gram positive. As I said earlier, the choice of empirical gram negative will depend on the kind of infection you're getting in your eyes. So if it is Acinetobacter, then I may choose colistin or polymyxin B. If it is a coagulase negative, appropriately I will choose the drug which is effective against. If it is MRSA, I may choose vancomycin and teicoplanin. These are rough guidelines. If it is a gram negative and pseudomonas, and particularly in a neutropenic, femoral catheter, severely ill patient with sepsis, so I'll try to use a drug which is effective against pseudomonas. You may have to give candida cover. There are indications when to give candida cover. One is that if the catheter has been there for a long time, you've been given more than 3 antibiotics, prolonged use of antibiotics, patient is a blood related malignancy, solid organ transplant, prolonged use of broad spectrum antibiotics, hematologic malignancy. In these cases, you cover along with the rest of the antibiotics candida cover also. You can choose echinocandins, liposomal amphotericin B, or fluconazole only if the patient has never had a fluconazole exposure. Then if it is a seriously ill patient, you draw the blood, one from the peripheral vein and one from the catheter, and you remove the catheter and start the empirical therapy. That's the way to go about in a patient who is seriously ill. Patient who is mild to moderately ill but has a high risk factors, immunosuppression, evidence of severe sepsis, evidence of infection at catheter insertion site, proven bacteremia otherwise. So there also you will remove the catheter and send the 2 samples of blood culture. But patient doesn't have a risk factor, not seriously ill, you can draw 2 samples and you may not remove the catheter and just start the antibiotic therapy. Then what are the recommendations? What kind of organism grows? Like in Staph aureus or MRSA, Enterococcus, gram-negative, Candida, you always remove the catheter. But if you grow the coagulase negative catheter, there are options. If you don't remove the catheter, patient is not that ill, then you have to give antibiotics for 10 to 14 days. But if you decide to remove the catheter, then the duration of antibiotic is just 5 to 7 days. But if it is a complicated catheter-related infection, like patient is hemodynamically unstable, he's got endocarditis, he's got a suppurative thrombophlebitis, osteomyelitis, active malignancy or immunosuppression, in that case also you need to remove the catheter. So these are just summarizing. When a patient has a severe sepsis, bloodstream infection, the blood culture is even positive after 72 hours of giving antibiotics, and you grow Staph aureus, Pseudomonas, fungi or mycobacteria, you should remove the catheter. Then a word about the antibiotic lock therapy. Like when you don't want to remove the catheter and patient has particularly the long-term catheters, the antibiotic lock therapy can be used. And you instill about 2.5 ml antibiotics or saline along with heparin. And what they had seen was that if you introduce these, they remain in the catheter for a long time. So there was a meta-analysis published in 2006 where they compared when vancomycin was used as an antibiotic lock solution compared to the heparin saline solution, and they found the incidence of infection was much less when the vancomycin was used. The theory behind this is that when you use heparin and saline, it also doesn't allow the biofilm to form inside the catheter, so the infection doesn't colonize. So they found the vancomycin was better than using the saline heparin solution. So it is recommended with long-term catheters when they are not removed and should be only used with the IV therapy. Then the coagulase negative I have already covered. Then the Staph aureus, you should remove the central line, systemic antibiotics for minimal 14 days. Ideally, it is said that if you grow staph and patient has any complicated feature of central venous infection, then you should give 4 to 6 weeks. But most of the time, practices for these infections, we use 2 weeks of therapy. And transesophageal echo is strongly advised after bacteremia, or in a person where you are keep on growing blood culture, Staph aureus, again Staph aureus after 4 days, yet you are giving antibiotic, patient is not getting better, you should do a echocardiogram, particularly transesophageal echogram, to rule out vegetation because of the endocarditis. And blood culture should be repeated during therapy and 1 to 2 weeks after completion of therapy to look for relapses in a case where there is a chance of endocarditis. Enterococcus, again, if it is a vancomycin resistant enterococcus, you use linezolid and daptomycin, otherwise you remove the catheter. Gram-negative organism, you should remove the catheter, and antibiotics are given for 7 to 14 days. Similarly, for fungal infection also, you should remove the catheter. If there is a suppurative thrombophlebitis, you not only remove the catheter, you give antibiotics for at least 4 weeks. Sometimes the infected vein is also removed if the person has developed suppurative thrombophlebitis. Then the most important thing is the prevention, because it's more difficult to treat central venous catheter infection, then it is much easier to prevent central venous catheter infection. And now it is recommended that you should use the central line bundle strategies for prevention of central venous catheter infections. There are core strategies and there are supplemental strategies. Core strategy is that every day in the morning, does this patient require central line? Like the patient I mentioned, if he had become all right 4 days after the treatment, one should have removed central line. Because for giving antibiotic, you don't require a central line. You can use a peripheral line. Central line is used when a patient was hypotensive to resuscitate, to give appropriate fluid, appropriate vasopressor, you require a central line. Once you feel that this is not required, it should be removed. Every day in the morning, when you are taking around, there are a lot of fast hug and other things. I think central line should also be seen, because if it is not required, it should be removed. Then you should follow proper insertion practices, comply with hand hygiene, adequate skin antisepsis, choose proper site, perform adequate hub access port disinfection, and provide education on the maintenance of central line insertion. So I'll discuss few of them. This I have already discussed. You should remove the unnecessary lines. The second is that you should wear proper clothes. You know, there is a common practice, just wear gloves and start putting the central line. You don't know that your little sneeze, little infection can really disturb that patient. So you should wear a proper sterile gown and gloves, hair covering, mask, and large sterile drape when you are putting a central line. They will take little extra time, but you may save the life of that patient when you prevent the occurrence of central venous catheter infection. Then they had seen in this study that when they took a maximum sterile barrier precautions, the infection rate was much less, as you see in this slide, as compared to the controls. And this is the most important thing. The hand washing is the thing which must be done properly before you do any procedure in the ICU, particularly when you're putting a line. Then proper insertion practice, that means use chlorhexidine is the solution which is recommended, and use the maximum sterile barrier precautions and hand hygiene, as I mentioned earlier. The skin antisepsis, because chlorhexidine is recommended, because they have seen that when it was compared with the propyl alcohol and povidone iodine, the chlorhexidine was found to be much better than the povidone iodine. And this is in a meta-analysis also they found the chlorhexidine is better. So this is the solution which should be used for skin antisepsis. So this is a preferable skin antiseptic. Then the site selection, as I told you, femoral has the maximum but easier to put. So the normal you select the jugular, that's the commonest, and femoral should only be used if there is no other site and you have to use femoral, then only you should use a femoral site. Subclavian has the minimum chances, then followed by internal jugular, and the maximum is by the femoral lines. Then the supplementary strategies, there are 3: chlorhexidine bathing, antimicrobial impregnated catheters, and chlorhexidine impregnated dressings. The chlorhexidine bathing in an ICU, this is one of the studies where they found that daily bathing with 2% chlorhexidine impregnated clothes decrease the rate of bloodstream infection compared to soap and water. But I think logistically it is difficult to do in the ICU, but this is one of the things which can reduce the incidence of central venous catheter infections. But there's no data outside the ICU, it is only in the ICU. Then the use of antimicrobial impregnated central venous catheters. There are 11 studies done in till 1999. They found that when you use this decreases the colonization and this decreases the occurrence of bloodstream infection. But the only problem what they found was that there is a minimal risk of anaphylactoid reaction and the emergence of resistant organism. So this is another problem if you use antibiotic impregnated catheters. They are expensive also as compared to the normal catheters. The CDC has recommended that when everything else has been done, training, proper insertion, care technique, etc., then you should balance the increased cost and risk of resistance when you decide about putting in an antibiotic impregnated catheter. So it is not still that you should use in every patient, but one has to weigh all these things before putting an antibiotic impregnated catheter. Then the chlorhexidine impregnated dressings. This is a new thing which is introduced in the Indian market also. That means you use a biopatch, which is a antimicrobial dressing with chlorhexidine gluconate embedded in. It's a rounded thing which you put on the insertion site, and there are a lot of papers on this. And these are the few of the study where they showed the biopatch reduce the catheter-related infections. It is to be replaced weekly. And another study done by Mackey, who's done a lot of work on this. He showed that biopatch reduced the risk of catheter colonization. And another study which showed that significantly reduced the rate of CVC colonization. And the study published in 2005 by Chamber, he showed that sustained release biopatch reduced the exit side tunnel infections. So it is a dressing which protects the catheter for the entire 7 days. So it has to be changed after 7 days. And there is recommendation B1 for the use of biopatch in patients of central venous catheter. So the CDC recommends that use a chlorhexidine impregnated sponge dressing for temporary or short-term catheters in patients who are more than 2 months of age, despite adherence to the basic CRBSI prevention measures. So basically all those preventive measures must be there before you think of using a biopatch. And they have been used in literature quite frequently and they have found it to be effective. So this is a good preventive strategy along with other CRBSI bundle. And then UK hospital, they have a protocol to use this at the exit site dressing protocol. So summary of preventive measures, the core measures: remove unnecessary central lines because you should not have a central line if it is not required. Follow proper insertion practices, like proper gloves, mask, head cap, and the gown and the drippings. Facilitate proper insertion practices. Comply with hand hygiene recommendation when you are maintaining a central line, not only during putting a central line, maintaining a central line. Sister must wash hands repeatedly whenever she handles the lines. Perform adequate skin cleaning. Choose proper insertion sites. Perform adequate hub access port cleaning. Provide educations to the staff nurse and the people who are maintaining the central lines. And the supplemental strategies are like you implement the chlorhexidine bathing, use antimicrobial impregnated catheters in certain situations, and apply chlorhexidine site dressings. So just to conclude, this is one of the studies published this year that CL bundle is associated with lower infection rate only when compliance is high. Because in one of the studies they found only 38% of patients, 38% of the healthcare workers were complying with all these recommendations. There's another study published in the current opinion in pediatrics, and they have concluded that till today the most effective strategy is the use of evidence-based central line bundles, which includes the core strategies and supplemental strategies to decrease the incidence of central line associated bloodstream infection, and they are associated with decreased morbidity, mortality, as well as a cost to the healthcare system. So take home message is that in our country, gram-negative bacteria are much more common than the gram-positive, and they could be E. coli, Klebsiella, Acinetobacter, Pseudomonas, depending on the epidemiology of infection in your ICU. Paired blood culture with at least one from the peripheral port is recommended to confirm the diagnosis. For complicated infections, the CVC should always be removed. For uncomplicated intraluminal bacterial infections, in the absence of tunnel or pocket infection, 2 weeks antibiotic systemic therapy with antibiotic lock therapy add chances to salvage the central venous catheter, and the CRBSI can be eliminated if you follow this central line associated bundle which I was talking about. Thank you very much.